about the Agent-IDE trial, which is the paclitaxel-coated balloon versus uncoated balloon for ISR. It was published last March in JAMA. Just a bit of background. ISR is pretty frequent in patients that undergo angioplasty. It's about 5 to 10% of patients within the first year. There have been multiple studies that have looked at treatment for ISR with prior to the DCB era, drug-eluting stents being shown to be superior to POBA and brachytherapy. In the last 15 years or so, with more and more data coming out about DCB, there have been multiple trials looking at DCB in Europe and comparing it to other modalities. One, for example, was the ISAR-3 Desire, which found that DCB was superior to POBA, but was sort of equivalent to drug-eluting stents for single layer. In Europe, DCBs have a 1A indication, but given that there's a lack of randomized trial data from inside the United States, it hasn't been FDA approved at this point. In the US now, the treatment of restenosis is a 1A recommendation with the drug-eluting stent as of the last set of guidelines. So this particular trial, the question was DCB versus POBA for ISR. And the goal of the paper, as they said it themselves, was really to design a study to provide evidence to support approval or FDA approval for DCB devices in the United States. This is a multi-center, single-blinded superiority trial. So this was the inclusion, exclusion, eligibility. The inclusion, so they had to have ISR with an estimated length less than 26, and the estimated diameter visually by angiogram had to be between 2 and 4. For patients that were symptomatic.
Jake, before you do this, can we just go back to that last slide?
Sure.
And get Alexandra to comment? Because Alexander, is it a requirement that they go against a FDA approved therapy? Is that why they could not use stenting in this?
No, well, that's not really the issue. So currently there's no, I think go back one slide where you say that DES is a 1A recommendation, right? This is guidelines. There's no FDA drug-eluting stent that's approved for in-stent restenosis in the United States. So there's a disconnect, between recommendations, guideline recommendations, and FDA approval. So when you go in and you're pitching your study, at least in this case, they chose to go against POBA, which we all know is not, the best treatment for these patients, but is aligned with FDA approval. So, it would be very, very hard. I mean, I think maybe I'm jumping ahead in terms of like the discussion here, but it would be very hard for the FDA to say, well, no, you can't use a control of POBA, given the fact that that's actually the only approved treatment, FDA-approved treatment, right? So they wouldn't be able to say, well, you have to use DES because they don't, it's not approved. So that's an important kind of caveat and sort of disconnect between guidelines, clinical practice, and FDA. What happens is you get an approval of a device and that, nobody's, except in TAVR, but and in valves, but in coronary work, nobody's policing where you're using the device. And there's clearly, it goes off label. And therapies get, the evidence gets, shown, it goes into the guidelines, but it may never make its way to the FDA for an approval. So I think that's point one, and we can talk more as you discuss the approach and sort of how they came about with their control arm of POBA.
Thanks.
Thank you. So this was the inclusion and exclusion criteria. So as I said, visually estimated length less than 26, diameter between 2 and 4, again, visually estimated. And then for patients that were symptomatic, stenosis that was between 5 and 99%, and for patients that were asymptomatic, between 70 and 99% visually. And all the lesions had to be successfully pre-dilated or pre-treated. There were no requirements as to what modality people used to pre-dilate or pre-treat. Anything was available to the operators. And for exclusion criteria, it was STEMIs or Q-wave MIs within 72 hours, low or very high platelets, patients with either CKD 3B to dialysis patients, any lesion that was in a bypass graft, any left main disease, any vessel or lesion that had thrombus in it, and then if there was a vessel that had ISR but also had a proximal or distal stenosis that was greater than 50%, that was also included as part of the angiographic exclusion criteria.
What do you think about because we're running into the same issues with magical ISR. So many of these patients have chronic kidney disease. So I just, I wonder if they would have the same, it's obviously a little bit irrelevant when you're comparing two groups, right? But I just don't know if these trials are going to be applicable to the majority of the patients that we see with ISR is my concern on that, because so many of them are ESRD or CKD patients.
Yeah, no, I mean, I agree with you. I think most of the DCB trials that I've seen have had some exclusion criteria for CKD. I think you would be interested to see what it would look like with an all-comers approach.
Right, yeah.
But I don't know what that data would look like necessarily.
Yeah, I mean, it's pretty typical for, I would say the vast majority of approval studies to exclude patients with advanced CKD simply because mortality is higher, the outcomes are much worse. And, if you think about it, you're trying to identify a patient population where you can demonstrate the benefit. It's really you want to show safety, of course, but you're also trying to show efficacy. And, most of the pathways, the FDA pathways will, once you get approval, it's typically a conditional approval with a requirement to extend in an all-comers patient population. So I think that typically gets kind of pushed off to post-market surveillance. But you're right. I mean, the generalizability is always, it's always in question, right? The other thing to maybe talk a little bit about is this lesion prep. And if you think about it, so it must be pre-dilated, pre-treated successfully. And I'm sure if you dig into the protocol, there's going to be a lot of detail there in terms of what that means. And, the concept with DCB is that it's really sort of a drug transfer, right? It's not a primary therapy for the vessel. So essentially you're doing a primary treatment of the lesion, you're debulking, you're expanding if it's, if it's a stent under expansion issue. I don't know if the protocol actually required or recommended intravascular ultrasound, and Steve can speak to this, but that's so key, right, in ISR. But the key point here is in both groups, you had to pre-treat the vessel and it had to be successful. So and that applies to the balloon arm as well, right? So if you debulk and then you do balloon angioplasty and then you have the flow limiting dissection, that patient would not be randomized. So it's really taking out sort of those with acute complications if there were some. So that's just a little, thing to remember in these particular trials.
And per their protocol, so no imaging was required. But I can tell you from looking through the supplement that about 3/4 of patients in both arms got IVUS. It's like almost
Much
80%.
higher than normal.
Yeah, and I can also tell you that their requirement for successful predilation and pre-treatment was residual stenosis less than 50% and no worse than I think a C for grade C for dissection, if I remember correctly.
Yeah, I mean, I would say, you know, 70% is great for intravascular ultrasound, but in in-stent restenosis, it really it should be 100%, right? Steve, what do you think?
Yeah. Absolutely. I think that's
100%.
100%.
Totally agree.
Yeah.
But you are in a room of believers.
Well, right, but I mean, you know, I mean, it's worth pointing out because we go, oh, you know, compared to national average, which is what, 15% usage, yeah, it's much better, but 30% of these patients didn't have IVUS, and you know, I don't know what the split is, but most of the mechanism of ISR is just either stent under expansion or there's, you know, some issue with the initial procedure. So it's a key point.
And how about the success criteria for lesion predilatation? I know 50% is a classic definition for balloons, but is that enough? Like you prepare and you accept less than 50%, and then you go and deliver the drug, and then you're out.
I mean, I think, Alexandra, you were maybe the first author on this. I remember this paper from the brachytherapy era that the better result you get in your pre-treatment, the better long-term result you get after radiation. So, and 50% is not a great result, right? So
no, and those studies have been done with DCB, and it's very clear. So the better the acute result, the better the long-term results with DCB. So, and I would say 50% is very generous. You know, some of the other studies that are ongoing, we required, I was very much involved with the solution study design. That's an ongoing clinical study. I think it's going to be presented at TCT. I think they finished enrollment, but that was less than 30%. So being a little bit more aggressive with the acute results. So I agree. I think that's very, very lenient, and I think it would be interesting. I don't know if you've done that yet, but to look at, we're jumping ahead, Jacob, but you know, to look at the outcomes based on acute results, and I'm pretty sure they're you know, probably going to do that.
So for this, they randomized patients 2-to-1 to DCB to buff. And then they also further stratified randomization by center. There's like 40 or 50 US sites here. And then they further randomized this or further stratified this by single versus multiple layers of stent, which we can talk about extensively at the end. The protocol deemed that you could treat up to one non-target lesion before treating an ISR. So it had to be, and this had to be successfully treated. So that would be, you know, if you had ISR and RCA, you could treat an LAD before you treated the RCA. And then DAPT had to be for at least one month after the procedure. And then the follow-up protocol was for 30 days, 6 months, 12 months, and then there will be 5-year data at some point. Although obviously that hasn't been collected yet.
So Jacob, just again, the stratification, we'll talk about the single versus multiple layer, but stratification by center is in every single trial, interventional trial, that's stratification by center. The reason for that is that each center has its own ways of doing things and can influence potentially can influence outcomes. The other thing that typically happens in these clinical studies is that there's a cap on the number of patients, so the percentage of patients that can come from a single center. So depending, you know, if you dig into these protocols, you'll find it to be either 10%, 15%, usually no more than 20%, again, in an IDE trial. But just to address that.
They're pre-specified endpoints, so they had a primary endpoint of 12-month target lesion failure, which was a composite of ischemia-driven target lesion revascularization, target vessel MI, and cardiac death. And then had the singular components of the composite outcome as secondary outcomes, as well as stent thrombosis and some quality of life data as well. And then target vessel failure, I should mention also, which was a composite of failure in the vessel, but not specifically the lesion. Their analysis for this, so they used an adaptive group sequential design, which is sort of a newer way to do sample sizes. So they pre-specified a sample size of 480. And then it was powered 85% at a sample size of 480, assuming event rates of 11% and 21.2% in the DCB and pulled arm, respectively. And they based these event rates on a network meta-analysis of DCB trials. I think they came out, I want to say 2 or 3 years ago. I can't remember exactly when. And then the way the adaptive group sequential design works is essentially if your results look promising, but your event rates aren't as robust as you anticipated because they allowed for a significant amount of variability in these event rates, or were anticipating a significant amount of variability, you could increase your sample size up to 600, which was pre-specified in the protocol to make sure that you were appropriately powered. And the way that they do this was they allowed a single interim analysis with once 90% of patients were enrolled to see whether or not, one, it was going to be appropriately powered, and two, whether or not, and then if they needed to increase sample size. And then they used a z-test with unpooled variance to compare the differences in proportion for primary endpoints. And then we looked at cumulative incidence functions as well.
So again, you should invite Helen Parisi to come to these. Well, she's maybe a little bit early for her, just to talk about the statistics. But so a couple of things. One is the interim analysis that's described here in the methodology. The way this is done is that you can look at the data, you can see if your event rates and your effectiveness assumptions are on par with your assumptions. If they're not, the way this works is that you can actually increase sample size. So you can't, there are different ways of doing interim analyses. This way, you don't have to correct for alpha. So you never have to adjust the power of the study. You're basically saying up front, here, if our assumptions are fine, we can finish at 280, but we can go up to 600 if necessary, and we don't have to adjust the alpha. So that's one key point. The other key point about this is the primary endpoint here is TLF at, when did you say it was? It was
12 months.
12 months. So, by the time, if you think about it, by the time whatever percentage of patients have reached 12 months, most of your patients are going to be enrolled in the trial, right? And the last thing you want to do is interrupt a clinical study while it's going, because to say, well, we're holding off, we're looking at the data now, and we're putting all the sites on hold is the worst thing you can do, because then reinitiating your sites to get back on board is really very difficult and sort of delays stuff. So this is just a very nice mechanism to essentially take a look. It's a safety valve if you want, but it doesn't impact the power of the study.
That actually was a great comment, because that happened in the study. They actually, the recruitment rate was much faster than they anticipated. So they couldn't do the interim analysis, and they went up to 600 without any interim. The FDA recommended them to do it because it was pre-specified, but there was a supplemental, and then it didn't inform anything about the sample size. They went up to 600 because of the fast enrollment.
Yeah, That's a point for the result. I mean, I think they had their enrollment was so quick that they basically had to consult with the FDA,
Yeah.
as you mentioned, to figure out what to do about analyzing, the primary analysis being with 480 patients or with 600.
Yeah.
And so in conjunction, they ended up doing 600. But I can tell you they also did analysis on a sample size of 480 as well with similar results.
Yeah, so that's interesting. I mean, it makes sense when it makes sense if your primary endpoint is at like 30 days and you have the opportunity to get in there and look and affect, impact the trial enrollment. But in this case, it just didn't make sense. That makes sense. Thanks, Daniel, for that comment. I didn't know that.
So these were the initial results. So they assessed a little over 2,500 patients for eligibility. About 1,900 were excluded and almost all of them were excluded on the basis of angiographic eligibility. Most of them because they didn't have in-stent restenosis. 68 didn't meet clinical eligibility. So I didn't have this in the exclusion criteria, but they excluded patients with COVID for reasons of presumably for reasons of thrombosis. And then they excluded a couple of other patients for withdrawn consents, didn't meet both, and then no cardiac catheterization actually ended up being performed. And they came out and randomized the 600 patients, 406 to the paclitaxel group and 194 to the POBA group, with pretty reasonable follow-up. I mean, they were accounting in their analysis for about a 3% attrition rate, which looks about close to accurate. They got clinical follow-up to a year at 390 in the DCB arm and 184 in the POBA arm. And obviously, this was intention to treat analysis. This was sort of their table one. I'll sort of summarize it because it's a lot of data. But basically, mean age was late 60s, predominantly male, predominantly white, about 3/4 for both of these. BMI is sort of in the 30, about 10% smokers, mostly hypertensive, mostly hyperlipidemic, lots of coronary disease, 50% diabetic, and 50% prior MIs. And then a quarter had left main disease, about a fifth had PVD, and then CKD of some sort was only about 1 in 5, which I think is the one thing that stood out as sort of non-consistent with the general coronary population that we see. And you can see here the indication for procedure, about half the patients, it was for stable angina, and then almost the rest of the patients were for in-stent use. There were a couple for silent ischemia and then for other indications, which were there were myriad other indications. These were the lesion characteristics. So we sort of touched on this briefly, but you can see like 60% of the patients had just a single layer of stents in the study. And then it was a pretty reasonable spread in terms of the vessel that was involved, RCA, LAD, and CIRC. And the average lesion length was about 12 millimeters in both arms, and the reference diameter was somewhere between 2 and 3. This is from the supplement. This was the procedural characteristics. The clinical success was about 90% in both arms. And then the procedure time and contrast was higher in the paclitaxel arm than it was in the uncoated balloon. You can see here intravascular imaging used at any time during the procedure was about 70-75% in both arms. Bailout stenting only occurred in a very small percentage of patients. It's 3 in the paclitaxel coated group and then 1 in the uncoated in the POBA group. And these were the devices used for pre-treatment. The only major difference here was that cutting balloons were used much more frequently in the DCB arm than they were in the uncoated arm. Otherwise, it was reasonably equivalent for the two.
It's interesting that scoring balloons are much more commonly used in public access than.
I don't have a good reason for that.
Well, people speculate that cutting and scoring balloons could create some deep cuts in vessel, facilitating drug to penetrate, but that has never been shown to be, superior than just pre-dilating a regular non-compliant balloon. So I think people still have that in the back of their mind and they keep doing it. And we see that translating into clinical trials, but there's no evidence that this is better than just regular pre-dilatation.
Or worse.
Or worse.
And this was the percent stenosis, and as we sort of touched on, also the acute pain that patients got across the board. So it was relatively equivalent, but about 1 millimeter, give or take, in segment, a little over 1 millimeter in lesion.
So just again coming back to your in lesion in segment, the diameter stenosis. How do you have any idea how this compares to stent results?
So what? I'm sorry.
To stent, if you put a stent in these lesions, what would you expect the residual stenosis would be?
I mean, I think the residual stenosis would be less with a stent. I don't have data. I mean, I don't know the data off the top of my head to support that, but that would be my supposition.
Yeah, I mean, typically, if you look at the drug-eluting stent in-stent restenosis, it's probably going to be around 10% residual or less. So, just again, coming back to, our control here, where we're looking at a 22% residual, in lesion. So that means actually in the stent, residual stenosis is high, right? And you've got a standard deviation there of 10. So, some of these lesions are left behind with a lot of residual stenosis. So it's, just again, the control is, we can discuss this further, but, this is the point, right? You're left with a lot of disease at the end of the procedure.
Yeah, I think reassuringly it was much less than the 50% that they pre-specified, but still not not ideal.
Yeah, it would be nice to see the range. I mean, you have the standard deviation. I don't know what the range was. And again, I think this would be a great sub-analysis to look at this. Unfortunately, we were not part of Agent, so we wouldn't be able to request that. But I hope somebody does that.
This is by QCA, presumably, right?
Yes.
Yeah.
Alexander, do you think this is a reflection of what the protocol says? People were looking at less than 50%. So once they achieve that, they just stop doing stuff and
No.
or this is just balloon in general.
I think this is just, what you see with balloon treatment of in-stent restenosis. And again, I mean, Jacob showed it nicely. It's you had 40%, 45% of double stents. I mean, those, as you know, don't really expand well, right? So I just think this is what it is.
If you cannot expand, you need to move something.
Exactly.
There's no way to gain movement.
Yeah.
Well, I mean, the acute gain here is pretty minuscule.
Yeah.
Right? I mean, it's yeah.
Yeah, in a 3, so the vessel size, if you go back to the prior slide, the vessel size is about 3.0. QCA was measuring 2.7. So by eyeballing, that would be about a 3.0. So again, if you're using in a non-stented vessel, right? If you put a stent in a non-stented vessel, you expect your acute gain to be 2.5 or more, right?
Yeah.
In in-stent restenosis, it'll be less than that with a drug-eluting stent or a stent. And here, go back to the next one, you're looking at a 1.2. So I mean, yeah, your acute gain is not great. Yeah.
What percentage of diameter stenosis is considered clinically significant?
I'm sorry, what's the question? What's the
What percentage of diameter stenosis is considered clinically significant?
I mean, it depends on the context, right? So if somebody comes in with angina and it says 60% stenosis, that's clinically significant. Is that what you mean?
Yes.
Yeah.
So even if it's like 30%, 40%, it might still be significant.
Yeah, so we know from the FFR data that angiograms are poor estimates of, severity of restriction of flow, right? So something that looks 30% or 40% by an angiogram can have a very positive FFR. So these are crude measures, to say the least, but that's why it's important to recognize that this is angiographic analysis and to put these numbers in context, like Dr. Lansky just did, you'd expect the acute gain with a stent to be 2.5, and here it's 1.2, which is pretty
Yeah.
good.
Okay.
Yeah, so just so again, in the context of a clinical protocol, what we would say is if you have nothing but angiography to go by, you would want to include a 70% visual percent stenosis, 70%. Anything that's intermediate, and Daniel can speak to this, intermediate meaning 50 to 70, you'd want to do physiology or some invasive measurement to figure out whether that's physiologically significant, right? So that's just a benchmark for you to think about. Again, goes back to this whole concept that doing physiology is really important in the intermediate lesions.
This was the dual antiplatelet use in the two groups. The summation here is that almost everyone was on some form of antiplatelet agent at 12 months. And many people were on dual antiplatelets, about 80% at 12 months.
Nobody.
There was I will say, this lists everything, but there was a 0% of the patients had ticlopid. So it was not used. It's just in this.
I saw this last night. I said, what the heck?
Yeah, no. There was no ticlopidine used for this.
Okay.
Yeah.
We still have some. They keep it in the historical library.
So that's kind of interesting, right? Because the protocol said a minimum of 1 month.
Yeah. The people are still using for a year.
And here, the vast majority of patients are on the APT at 12 months. One of the future kind of indications for DCB, of course, is patients with high bleeding risk. But Steve, what do you do with your patients with ISR? I mean, if in this scenario, if you use a balloon, do you continue treatment for 12 months, or do you stop early?
No, I stop aspirin pretty routinely early.
Yeah.
And then,
30 days?
Yeah, 30 days. Especially people with high bleeding risk. But as you know, I'm an aspirin unbeliever, disbeliever. So I stop it early.
Does it matter for your indication? So if the patient came in with ACS and was treated with DCB, would you still do it, stop at a month?
Yes, I'm a zealot.
Okay.
Trick question, Jacob. That's actually a really good, because the guidelines would say continue for 12 months, right? Because of the ACS.
Yeah. I mean, that was when I looked at this, my sort of thought was most of the people that made it to 12 months were patients that came in with ACS, which was about 40% of the population, but I can't prove that. But that was sort of how I rectified the data in my head.
Yeah. Interesting.
Okay, so these are the outcomes. As sort of already anticipated by our build-up, DCBs were superior to HOBA for target lesion failure. There was almost an 11% difference, and the hazard ratio was 0.59, with the confidence interval between 0.42 and 0.84, which is obviously statistically significant. For the pre-specified secondary outcomes, you can see that vascularization was also statistically significant with a pretty large difference, and the target vascular revascularization as well, with a very large difference of about 10%. The remainder, the only other thing that was significant was target vessel failure. Myocardial infarction wasn't significant. Or sorry, excuse me, was just met significance, or almost met significance, 0.34 to 1.01 on the confidence interval. So a trend towards significance. Actually, not in favor of DCB, it's actually in favor of Clovis. And then death was not significant here. The stent thrombosis, I'll mention, there's 1 in the DCB arm and then 7 in the POBA arm, which is about 3 and change %. And these were the KM curves, which sort of just visually demonstrate what we just talked about. I'll mention they also performed 2 sensitivity analyses for this. The first was, I believe it was with the stratified, I think it was the stratified data, sort of by center and by layer, which was similar in finding. And then the second sensitivity analysis they performed was with accounting for the competing risk of death or non-cardiac death, which was also bore similar results.
So, sorry, go ahead. I mean, I just think it's worth commenting on the event. So, you know, so I think takeaway number 1 is most of the benefit here is based on ischemia-driven target lesion revascularization. You can comment on you know, what the rates of all revascularization might be between the 2 groups, but basically take a look at the curves there with revascularization with balloon, with plain balloon and in-stent restenosis, 25% out to 12 months. I mean, you know, that curve is pretty steep. So you're basically shifting that curve down, right? The other thing, when you were showing the table and the myocardial infarction, I always find it very frustrating the way they present this. For me, when I'm thinking about my myocardial infarction, I like to think about peri-procedural MI versus spontaneous MI, and they never present it that way. Procedural MI, you know, it's like troponin leaks, right? And there's this huge debate about clinical relevance, etc. I mean, you know, obviously, if you have a 5-time, 10-time increase in your troponins, that's a big MI. But many of them are not, and the definition of MI is really important in that context. What's more important is spontaneous MI, right? So what happens well past the procedure? So if you look at your Kaplan-Meier curves, if you go to the next slide, it kind of answers that question when you look at the target vessel-related MI. In the early phase, there's no difference. So it seems like most of these MIs actually are spontaneous. They're happening, you know, well past the procedure itself. And I think it may reflect, again, you said there's more stent thrombosis, there's more events with the balloon. That makes sense. So,
yeah,
right. So both target vessel revascularization and MI is driving that primary endpoint.
One comment about that is that in the past, people assumed that restenosis was a benign event, right? People would come with chest pain, and then you would recat and intervene upon. So we are looking that 40% of the population presented baseline with an acute coronary syndrome. But that's not benign. And then when you look at these curves, the MI curves kind of mimic the ischemia-driven TLR, meaning that some of those recurrent events are not as benign as we assumed, and they come with an MI, right? So because they are a spontaneous MI happening around 2-3 months after the procedure. So some of those restenoses are actually coming with probably an occluded vessel or a subocclusion that, you know, lead to an MI.
But I would counter that the historical feeling that restenosis is benign is pre-troponin, right?
Yeah.
So those people came in with progressive angina.
Mm.
Their CKMB was negative, so we just called it unstable angina, but they were fine. And I just remember from the, that when drug-eluting stents came out and had that big stent thrombosis problem, and people kind of pointed to the fact that restenosis is a benign thing, and now we're trading restenosis for stent thrombosis, but it's all pre-troponin. So again, the definition of MI is kind of important, right? They come in with progressive angina, had a little bit of high sensitivity troponin that was positive.
Yeah, they use the SKY definition for the peri-procedural and then the fourth universal for spontaneous.
So just one positive troponin is the fourth universal, right? Yeah. So that's
So that explains. So thanks, Jacob. So and I think it's a great point. So the fact that they're using SKY definition. So the SKY definition, I think uses, well, it's predominantly based on CKMB. And I think to qualify for an MI, you need to have, I forget, but I think it's at least, isn't it like 70 times an increase? It's a really impressive difference, right? Or
Yeah, right.
increase.
But that's for peri-procedural MI, no?
Right, for peri-procedural. And I think, what the SKY definition does is it's really sifting out all the little leaks that Steve's talking about, right? When troponin is so sensitive. And that's what triggered this whole debate about what does it mean to have, a 2 or 3 time upper limit of normal of troponin. Well, the reality is for the most part, that doesn't mean anything in terms of prognosis, in terms of linking that with mortality. So again, coming back to these curves, it makes sense to me that they're using the SKY definitions in the, for peri-procedural, and that explains why those curves are totally superimposed. And then when you shift over and start using troponins for your spontaneous MIs, that's when you start detecting the difference. So just, it's kind of interesting to look at this and to understand how it's being defined. The other thing I would say is that, when looking at these MIs, it's actually a good thing to have a table that compares the troponin levels, because I find that just way more informative than just saying, do you qualify for an MI? And what is the definition? And most people are not, not thinking, they're not digging or drilling down to this level of detail. But if you show in a tabular form what the troponin thresholds are, and you can compare them by group, I think that's just a lot more, informative.
Yeah, the SKY definition is 70 times upper limit of normal for
Right.
troponin. So
it's
70.
really looking at the big complications in that peri-procedural time frame, right? And that they came up with that because that was the threshold that was correlated with poor outcomes, and I think it was mortality. They linked it to mortality.
And this was just some hypothesis driving subgroup analysis that they did. I would point your attention to the fact that multiple layers of stent certainly favors DCBs over a single layer here, overlaps with a non-significance. There are a couple of other sort of subgroups that look like they may there may be some favor with the DCB arm, such as older patients without diabetes. But I think sort of the one that drew my eye was the stent layer here.
Yeah. So why do you think let's look at those 2 dots and kind of say, okay, maybe there's a bigger, there's a bigger treatment effect, right, in the multi-layer. So why do you think you're seeing that? We're seeing that.
I just don't think that POVA works in multiple layers.
Exactly. It's not necessarily that DCB is so much better. It's just that the POVA is just really bad for multiple layers.
Yeah, and I sort of think that gets to sort of my summation of this study. Essentially, this was a study that was designed to be positive. It showed that TLR was significantly better in patients that got DCB when compared to POBA. We sort of already knew that. And so I don't think that this is anything that is groundbreaking, especially in patients that have, I would say that the other interesting aspect of it was the stent layers as well, which doesn't seem like it's designed to apply guideline treatment. Right? Like if you have a single layer of stent right now, with this, you would certainly think about putting in an additional layer versus a multiple layer where you would be thinking about modalities such as POVA or whatever else you want to reach for depending on the characteristics of the ISR. So, I mean, I think that was a major sticking point for me. But those were sort of my two main takeaways. Was that one, this was sort of already set up for success. That I don't know if they selected the populations as well as I would have liked. And a more interesting comparison, for a single layer would have been something like a DCB versus a POBA versus a DES. And then for a multiple layer, something like, just I think a POBA versus DCB is reasonable in a multiple layer, but obviously other modalities could be included.
So
So we're gonna make a trialist out of Jacob because this is exactly the conversations that go on when you're trying to design these studies and you're taking them to FDA for an approval. So on the one hand, you want to set up your trial for success. Obviously, if you're going into FDA to do a clinical study, you to get approval of your device, you're not gonna set it up to fail, right? You're gonna do whatever it takes to have a successful trial. So that's number one. I think, just to put this in context, ESC put their recommendations. I think it was what's the date on that? I think it was about a decade ago.
Yeah.
It was like early 2020s, 2012, 20 something. So we're behind here in the US. We don't have access to DCB. And I think, again, I mean, this is a good conversation to have, and everybody should pitch in, but there are plenty of situations where you want to have DCB, as part of your tools to treat your patients, right? Multiple layers. Well, is putting a third layer of stent really the right thing to do in our patients where we know that stent thrombosis rates are higher, etc. Smaller vessels. So if you have an ISR and a smaller vessel and you put another stent in there, I mean, that's not great. There are plenty of situations where, having access to DCB is a good thing. And I think that in that context, the reason why, the investigators were so eager to enroll these patients, I mean, as you said, they were like enrolling like crazy, is not because they thought the POBA was the right thing or that the design of the trial was necessarily the right thing. But I think everybody agrees that we need to have DCB approved in the US for and accessible to us and our patients to be able to kind of like have that option. So I think that's what drove the enrollment and sort of the decision on the trial design. What is the best? I mean, I don't know. I'll pitch it back to Steve. What is the best thing? You've got a patient here who's got a 2.5 vessel, two layers of DES and a lot of intimal hyperplasia based on IVUS. What are you going to do with that patient? I mean, we have the option of vascular brachytherapy, but now we have the option of DCB. So, is it worth trying that? I think that's a clinical question, and then obviously, every patient is different. But I think the having the option to treat with or avoid putting more metal in the vessel, I think, is a good one.
No, I agree. I think, that's why IVUS is so important for OCT, intracoronary imaging. If it's purely intimal hyperplasia, then I kind of also feel that, Roxana Mehron's kind of classification of how severe the in-stent restenosis is also is relevant. If it's focal, then I think balloon angioplasty is fine. The event rates are pretty low there, 20% or so. But once you start to get into these proliferative situations where the whole stent's full of stuff, or it extends outside the stent, then I think that's where you have to decide about a second layer or DCB or radiation. So I think it's great that we have DCB. I agree. I think single layer, kind of these proliferative ISR, I would reach for DCB as your first option in that patient over another stent or any other modality for sure.
Yeah, I think to that point, if you go back to the angiographic criteria, these were relatively focal. So I think you're making a good point. If you're looking at a diffuse proliferative ISR, I mean, it may be worth trying DCB first, but the likelihood that that's gonna fail is relatively high, and then you can go to radiation on those patients, right? Where lesion length of 12 millimeters, right? So that's pretty focal.
Yeah, the other thing too that we've learned is that, radiation is better for patients with renal failure. So, I think if you have somebody with normal renal function, you're going to default to DCB. If you're going to have somebody with a creatinine of 4 or on hemodialysis, that's a situation where, for whatever reason, radiation has turned out to be a real different modality than it is in somebody with normal renal function. So, so all kinds of things can influence your decision about what modality would be best in any individual patient.
Is there a hypothesis as to why for radiation is better in patients with?
Well, no. I mean, I think we know that people with on dialysis have very aggressive vascular disease. So whatever the cellular response is to arterial injury is exaggerated. And that's the thing that you're treating with radiation, right? Is that response to injury.
And balloon is probably worse too.
What's that?
Just plain balloon is probably worse.
Yeah. And so, obviously radiation is gonna be most effective in people who have the most aggressive cellular response to injury. So diabetes and renal failure turned out that it's actually better than people who are not diabetic and don't have renal failure.
So I think the takeaway from this is, in those lesions, Steve, that you say, they're focal and you could use a balloon. What this is telling us is if you use a DCB, you're going to have a 50% reduction in your TLF at 12 months. And if I'm the patient, I'll tell you that that's certainly worth it. And it's safer, right? Because you don't have any stent thrombosis, your MI rates are lower. So I think that's what the takeaway from this is. Just to give you a glimpse, in your question, Jacob, about the controls. So there's a trial called that we actually were part of at Yale. It's the solution study. It's a sirolimus eluting balloon in in-stent restenosis. They also have a small vessel randomized clinical study ongoing, but that study used a blended control. So there was I think it was like 25% POBA, and then the rest were DES for the control. So that's more aligned with clinical practice. And again, I mean, FDA, I was involved with those negotiations with the FDA. FDA doesn't push back. They acknowledge that, that's the standard of care actually for the most part in the US. And if you go and pitch a study where you're using a real standard of care control, they'll say, okay, well, we want to understand what the benefits are. So when you're doing that, you're shifting your hypothesis from a superiority compared to balloon angioplasty to a non-inferiority compared to drug-eluting stents. So it just changes how you're looking at the study, it makes it a little bit complicated because you know, the details of the conversation with FDA is, well, they wanted to cap POBA in that trial because they don't want POBA to be driving the non-inferiority design of your study, right? They want to make sure that if we're going to use DES in there and we're designing this for non-inferiority, that we have, you know, majority of patients are treated with drug-eluting stent. So it just changes a little bit of the, you know, how you think about it, how you design it, you know, etc. That study is enrolled and will be presented, I think, at TCT in October. So Jacob, maybe you can come back in October, November and discuss that trial. I think it's going to be really, really interesting. It's interesting because, you know, this one is paclitaxel, right? And most of the DCBs until now, all the ones that, you know, have been tested and approved in Europe are paclitaxel DCBs. So solution is a sirolimus DCB. So it'll be really interesting to look at those outcomes. So
It's interesting that that they're willing to do that study because the data from Europe is that DCB loses to drug-eluting stents, you know.
Yeah.
Better than POBA, but not as good as a second stent. So are there 2 layers in solutions also?
Yeah. Yeah,
Oh.
and there's you know, strong recommendations. If you have a single layer, you use a drug-eluting stent. If you have multiple layers, then you know, it should be a preference for balloon. And again, we know that balloon doesn't do well in those lesions. And there's a whole protocol and recommendations as to what to do. There's strong recommendation to use invasive imaging to guide the pre-treatment, and it's all about that pre-treatment, right? So the whole algorithm for pre-treatment, vessel lesion debulking, etc. I mean, was again a key point in this, and you know, when we look at these results and those results, I think it's really, really, really important as this therapy gets put out there for people to understand that this is not. DCB is not a primary therapy. It's a you know, drug delivery system. That's all it is. It's you go in low pressure and you deliver your drug. That's all it is. So all the work to, you know, to get these lesions treated as best you can happens before the DCB goes in.
Was intracoronary imaging mandated in solutions?
It not mandate. So there's you know, we love to mandate stuff. If you mandate stuff, then it goes to protocol violations or deviations. And that's always a big issue because you get dinged again from an FDA regulatory perspective. So the way around that is you say it's a strong recommendation, and then when you do all your investigator meetings and you know you're explaining why that's so important, right? Why we need that. And it drives, you know, it drives better outcomes, and it's the right thing for the patients.
Absolutely.
Yeah.
All right. Well, Jake's gonna come back in October.
Yep.
It's set.
Set.
All right.
Thank you, guys.
Awesome.
Thank you. Thanks, Jacob. Bye-bye.
Thank you.